So concerning brain metastases, so it was very interesting because definitively now we know that the combined therapy with anti-PD-1 and ipilimumab, I mean immunotherapy, is the best treatment for brain metastasis. Question, is it to use alone or with radiostereotaxis? The future, and I think in the next year we will have the answer. But definitively, even if you have a patient which is BRAF positive, we are now discussing to use this combination first. So concerning the toxicity of immunotherapy, clearly we have more and more toxicity, but what we know is that they start early, but they disappear after. So we have many different cutaneous manifestations, so it could be a problem of diagnosis. And when you have severe, I mean grade 3 or 4 adverse event, we know that it could be in link with a clinical response. We don't know. We don't have still the answer about that. So, but probably in 1 or 2 years, yes, because so clinical trials are ongoing. So at the moment, so really we are more in the combination. I mean that, by example, anti-PD-1, we don't use it alone for melanoma, but we are combining anti-PD-1, anti-PD-1, and ipilimumab. You are more in this kind of approach. It means that we know today that we have around 50% of response with a combination, and even in some situations, 60–70%. I mean with ipilimumab and anti-PD-1. So now it means that we would like to increase. So for the 30% of patients not responding to treatment, it's why we try either to combine so targeted therapy with immunotherapy, or immunotherapy, another third monoclonal antibody. So definitively in melanoma, it does not work. It means that you can have 1%, 5%. We try different things. It's not a good marker for clinical response for immunotherapy. It's completely different in other type of cancer. I think that we have mainly the TIR, which is very important, that is the infiltration by T lymphocyte. For me, it's probably one of the best markers that we have today. I think now we can already say if you have brain metastasis, so now we have a treatment with immunotherapy. Minimum anti-PD-1, and if you can use it, so the combination is even better, because from 20% of clinical response, you could increase, associating with ipilimumab, 40% of clinical response. And probably, so it would be interesting to make the association between immunotherapy and radiotherapy. So we know that we don't increase the adverse event, but the question is to have exactly the same tool, the same machine for radiotherapy, and that is the main problem today, and also according to the profile of the radiotherapies. So it means that here we have a variable that we have to manage.